My name is David Wang and I am currently a PGY3 in the Emory Internal Medicine program. My presentation is on an unusual presentation of refractory spontaneous Salmonella peritonitis in a cirrhotic patient. Some learning objectives I have would be 1. To identify non-typhoidal Salmonella as a cause of persistent SBP in patients who are immunocompromised or have an occupational risk. 2. To demonstrate the importance of diagnosing persistent SPP early because of the poor prognosis it portends in patients with advanced liver failure. And 3. To recognize Salmonella SPP that it may require a prolonged course of antibiotics and additional investigation for possible sources of gut translocation. Just a brief introduction, SBP is the most frequent bacterial infection in cirrhotic patients in up to an estimated 20 to 30% of patients, with a mortality of up to 30%. Pathogens commonly include E. coli, strep species, and Klebsiella pneumoniae. Salmonella is a highly rare cause of SBP that is most often associated with immunocompromised states. For our case, this is a 61-year-old with decompensated non-alcoholic steatohepatitis, cirrhosis, and end-stage renal disease, presented with sudden onset hypotension during a transplant eval TTE and 3 days of fatigue, lethargy, and loss of appetite with a social history of breeding chickens for the past few months. He was afebrile, blood pressure was 70/40, and the abdomen was distended without tenderness to palpation. Initial diagnostic paracentesis revealed 13,000 white blood cells with neutrophilic predominance. Culture of peritoneal fluid revealed pan-sensitive Salmonella and negative blood cultures. He was diagnosed with SBP secondary to Salmonella and treated with a 7-day course of ceftriaxone with transition to levofloxacin. Despite completing a course of ceftriaxone, repeat paracentesis revealed increased white cell count to 26,000 and acidic cultures remained persistently positive for Salmonella. CT of his abdomen showed no abscesses, bowel leak, or other intra-abdominal infections. He was restarted on a 4-day course of ceftriaxone, after which peritoneal fluid shows improved white cell count without bacterial growth. However, given his refractory SBP and inability to tolerate dialysis due to hypotension, he was transitioned to home hospice and discharged with cefpodoxime. Non-typhoidal Salmonella is a rare cause of SBP, with previous case reports citing immunocompromised states such as AIDS and extrahepatic malignancies as risk factors. However, in our case, occupational exposure to poultry placed this patient at a higher risk, and ESRD may have contributed to an immunocompromised state. Previous reports of Salmonella SBP responded well to a 1-week course of ceftriaxone, after which patients typically showed decreased neutrophils in acidic fluid and clinical improvement. However, in our patient, repeat paracentesis revealed an increased neutrophil count despite appropriate therapy. This failure to respond to treatment necessitated additional investigation with CT imaging to see if there was an abscess or intra-abdominal infection, of which none was found. This patient eventually responded to a prolonged course of ceftriaxone despite initial resistance. It is important to recognize persistent SBP as it can occur in end-stage liver failure and portend a poor prognosis, suggestive of hepatocellular carcinoma or gut bacteria translocating into the peritoneal space. Heightened clinical vigilance and patient-centered communication about a guarded prognosis is necessary in these situations, given the high mortality rate associated with persistent SBP despite patients feeling relatively asymptomatic. These are my references, and thank you for taking the time to attend my poster presentation.